Hello, I'm Bobby Watts, the CEO of the National Healthcare for the Homeless Council, and it's my great privilege and pleasure to welcome you to our second COVID-19 Town Hall. Today's subject we will focus on reaching unsheltered people. And we're very privileged that we have two giants in the field with tremendous amounts of experience, both nationally and internationally, devoted their careers to providing care to people experiencing homelessness, and have really been innovators in reaching people experiencing homelessness. We have with us Dr. Jim O'Connell from the Boston Healthcare for the Homeless program, and we have with us Dr. Jim Withers from the Street Medicine Institute in Pittsburgh, which is based in Pittsburgh. We are here because the COVID-19 pandemic has really affected how we deliver care, and it certainly has underscored the importance of reaching people experiencing homelessness because they are at increased risk of coming into contact with the virus, and the conditions of homelessness weakens their immune system, which makes it more likely that that virus will develop into a disease. They will not be able to fight it off. We've looked at sheltered homelessness, and we also now really want to focus on reaching unsheltered people. A few technical issues. There is a chat box on your screen. You can write questions in there at any time. Our format for today we'll have presentations first for about 10 minutes from Dr. Jim Withers, then from Dr. Jim O'Connell, and then I will ask them some questions that have been sent in with those who registered. When they registered, they asked questions. And then we will pick some questions from those that are being posted in the chat box. If you have any questions or tech questions, you have problems, you can call Caroline Gumpenberger at 615-226-2292, extension 222. We are recording, and we will post this online with slides in 3 business days. So I really want to, again, just tell you a little bit about the Council if you don't know us. And want to begin by reading our mission statement. It's our new mission statement as a result of a strategic planning process, and it is that grounded in human rights and social justice, the Council's mission is to build an equitable, high-quality healthcare system through training, research, and advocacy in the movement to end homelessness. The genius of the Council that we take the experience of those on the front lines, both people with the lived expertise of homelessness and those who are providing services to them, bring that to bear. We share lessons and we learn from each other, and with a constant striving to get better. The Council has been extremely active in putting together some resources around responding to the COVID pandemic. I really urge you to visit our resource page, nhchc.org/coronavirus, and we also have some resources specifically on street homelessness. The slides are listed there, and the resources are in your resource box, and really encourage you to visit them. We also have there some recent guidance that we'll hear more about from the Street Medicine Institute on responding to COVID-19 for those who are unsheltered. If you have any questions, and we also ask you to share your resources with us. We have local guidance from different cities as everyone is trying to figure this out how to respond. So if your community has guidance, please send that to Michael Durham, mdurham@nhchc.org. I also want to thank Michael Durham, our Technical Assistance Manager, for organizing and preparing for this webinar and putting the materials together and conferring with the speakers to get ready. And both Michael, he wanted to make sure we address this, as do I, and that is as we are responding to the COVID pandemic, we must pay attention to structural racism. At the Council, we understand, as many people do, that the nature of homelessness and how it's manifested in this country is inextricably tied to structural racism. History of segregation and forced segregation, but in federal policies in housing, has led to unequal access to housing based upon your race, and it's manifested in an overrepresentation of people of racial minorities of those who are experiencing homelessness today. So in our response to this emergency, we must make sure that we are not exacerbating those structural inequities, but instead consciously working to undo them. And a quote there, it can be tempting to table diversity and inclusion as a focus in a crisis, but it's actually the time to center it. So I'm going to turn it over to our panelists, Dr. Jim Withers and Dr. Jim O'Connell. But first, I just really want to express my thanks to both of them, and just an example of how we learn from each other in the council. About 18 years ago, when I was working in a program in New York City, one of the agencies that ran the street outreach program said, we have a little extra money, can you help us develop, can you bring medical care on the streets? And I immediately said no. I immediately said yes, without checking with my boss, because I had learned from many years of hearing how Jim O'Connell had worked in Boston with his street outreach services. And later, as that program grew very quickly, we learned about the Street Medicine Institute, sent the nurse practitioner on our Bronx team to the Street Medicine Institute's conference, and the doctor on our Manhattan team to the conference, just for all kinds of information that really helped that to grow. So I am personally indebted and know that their work has helped not people just in Boston and Pittsburgh, but really throughout the country and around the world. And with that, I will turn it over to Dr. Jim Withers. Thank you for being with us, Jim.
Thank you. Thank you for the leadership and for convening this important conference call. I hope, are you hearing me okay on my cell phone bypass mechanism here?
We hear you.
Okay, all right, thank you very much. So I guess we could go to our slides. So this is a effort for, let me first say that street medicine and the people that are homeless, in particular on the street, but throughout our system, it is a kind of a chronic disaster. So I think that the response that we're having is very congruent with our understanding of the inequities and the barriers and the disproportionate mortality and challenges that people on the street experience. This cartoon here, I thought, spoke to some of the response and where we are facing in terms of the health of our citizens right now. I want to make sure that in the first responders group there, that we include those who run our shelters, those who are right on the front lines, and those that are working with the daily supports of the homeless for the things that they just can't do without. And I want to thank those people as well as the medical people involved. Next slide. So, like most of you, I think the first thing that you experienced during your crisis was a shift from your daily activities to a lot of Zoom calls. And certainly the planning and the ability to find other community partners and to work more closely with them than we've ever done before has been a real challenge, but a blessing for us to pull together as a community and find solutions to problems in a way that's really coordinated. And so we have been, as most cities have been doing, getting to know our county even better, to understand and work with our health department and hospitals and emergency rooms and first responders. And in this case, this is a photo of all the street medicine students from around the country, but it just represents, I think, the beginning salvo of what we had to deal with. Next. So one of the first things that we had to do was retool our rounds, the processes. And essentially, we looked at the epidemiological considerations and balance them with, our moral imperative to keep seeing the patients and making sure that they were well and being good stewards of the public health part of our community effort. And so we decided that, in short, we would pretty much pull back most of our day-to-day activities and just limit the work on the street to a couple well-trained, experienced street medical personnel, along with an outreach worker, and decrease the rounds, but increase the ability of community partners to call in to us to say, we know of somebody who's not doing well and needs to be looked at and tested. Next slide. And that quickly evolved a couple weeks ago into the Street Medicine Institute taking this on and creating a document which is not perfect, but it was impressively done, and I think it's a good resource for anybody here. It's on the streetmedicine.org website, and I believe, Bobby, it's also available through Healthcare for the Homeless's website as well. So I would strongly encourage you to go there and look at this. It really does focus on the street part of this, and it breaks down the logistical parts, a lot of the considerations that we may cover in our questions. But again, I put that out as a pretty good resource for you all. Next slide. So in our initial response to the street, we had to really put our public health hats on and target some of the camps that had larger amounts of individuals for regular visitation because of their heightened risk, and then began to really lobby with our city to provide us resources that weren't there before, such as portable toilets, water supplies, and sinks. Next. So this is the sink, and I've tested it out. It works really well. We should have had these a long time ago, but it allows the clients to wash their hands and in a sanitary fashion, and we put those in around 4 of the major campsites that we have in town. Next. One of our staff demonstrating how it's used. Next. And so at this point, we were looking at trying to use the epidemiological principles of locating persons under investigation. And it was difficult, but we scrambled, and this is where I strongly recommend your social media and other platforms to try to put out feelers. And the community responded well, and we were able to get COVID testing kits from the University of Pittsburgh through that means. And so then we had to develop protocols for that field testing, step by step. Our parent organization has an incident command group that we have to run all these through. So it helped us to have to really write down the protocols for each of these. Next. And so pretty early on, we were able to get out there and do COVID testing. To date, we've had no positive cases in the street population, but we're trying to monitor and be on top of that rather than playing catch up. Next. So again, it's very mobile. I always like to point out this is our street medicine fellow. We have a UPMC Mercy street medicine fellow who's been a real blessing in terms of working out a lot of these protocol issues and doing the work. Next. And I just want to leave this. We can talk about the details and the dynamics, but these are really difficult times. Our staff is stressed. We try to rotate people through, and yet this is a picture I took from one of our camps the other day, and just a reminder that spring is here, that life does go on, and that it's really a joy to be in a place where we can serve people and feel even more deeply connected to each other. And then I'll be ready for questions and pass this on to Big Jim.
Can I thank you very much, Jim, and hello to everybody out there. Haven't been called Big Jim ever, I don't think, Jim. Thank you. Couple of things to just start out with. First of all, the fact that we're having this webinar today is a huge thanks to Bobby and to everyone at the National Healthcare for the Homeless Council, and to all of you who have been really advocating for sheltered and unsheltered folks and what's going to happen to them during this pandemic. And then a special thanks to all of you out there. I can only see quickly the list of people out there, but so many of you are actually on the front lines doing this every day. And all I can say is after doing this for 35 years, I am in awe of what everybody is doing. And I have been thinking just to start out with it, I first started as an intern at Mass General when the first case of AIDS hit. This was back in the early 1980s. And the epidemic hit the homeless population in 1985 when the Healthcare for the Homeless programs were starting. And I remember being frightened to death. We didn't have a test. We couldn't tell who had it or not until they got very sick, which was often, many months to years after they contracted the virus. But it taught us a huge lesson back then, which I think the Healthcare for the Homeless program around the country, and certainly the street medicine programs around the country and the world have learned, and that's that we're all in this together when an epidemic or pandemic like this happens. None of us can do it alone. We all have to be working with our partners in shelters, outreach, city, states, all of the social service agencies. And I also want to add the hospitals, because this is a time when we all have to be in it together. So with that is probably within a thanks. I did want to salute Jim and the Street Medicine Institute for those guidelines that are on the website. You should check them out. They're actually really fabulous. And I can say that with I had nothing to do with them. So to all the folks at the Street Medicine Institute, thank you so much. And then let me just give you a quick picture. There's so many angles to this. I think what we really want to do is to get to the list of really fabulous questions that I can see. But here's the issue that as we sort. So whenever there is an outbreak, an epidemic of an infectious or communicable disease, it puts, I think, homeless people, whether living in shelters or on the streets, at a huge disadvantage, which is structural and not anything to do with them. And every time this happens, it lets us realize that the only response to this in the long run is to make sure everyone is housed. But of course, in this disaster, getting housing for everyone is virtually impossible. And we are all doing whatever we can to address that issue now. In Boston, we have these. I'm kind of blessed. I'm like one of the old senior citizens now, sitting in the bleachers, watching these fabulous people, many of whom I hope are listening now, do these amazing things in Boston. And they're the ones that I get to work with and who really should be giving this presentation. But our program, like everyone else, has had to turn itself inside out, upside down, topsy-turvy in response to this pandemic. And everybody has had to take on new roles, changing roles, and the rules seem to change about every other day. So trust me, whatever you're doing right now, we know it's going to change, and we'll have to take a different approach in another day or two or a week. So please remember that flexibility as probably the most important principle going. So in Boston, we ran into the problem that I think many of you have, that the standard public health response to an epidemic like this is all the stuff you know: physical or social distancing, it's self-quarantining at home, it's washing your hands frequently, it's sheltering in place. And all of those cardinal principles of a good public health response, which apply to the general population perfectly, are almost absurd when you step into the world of a homeless person, because those are not impossible. So the challenge for all of us is finding out who might be sick or who might have been exposed. How do we make sure that we take care of them or have a space for them to be if they want it? And then make sure they're not mixing in with others and passing the virus around. So in Boston, our program, led by our amazing CMO, Jesse Gaeta, and Denise De Las Nueces, and Barry Bach, who's our CEO, and just about everyone else, just decided to tackle this full on. So we ended up realizing we have to screen people coming in or coming into the shelters. And as you may know, we have clinics in about 40 shelters around town where our docs and nurses and social workers are. So we screen at most of the shelters. when somebody was either had a contact or had symptoms, then we ended up realizing there was no place for them to go. And in a stroke of brilliance by Jessie, she conceived, and then eventually we got built these 2 tents, actually built by people that this mass design, a guy named Chris Scoville, who designed it with money from a local construction thing and a lot of support from the mayor, who, by the way, has been fabulous, and I hope your mayors are as fabulous as ours in this because we need them. But the 2 tents, one is for quarantine. There's about 20 beds for quarantining people who would otherwise go home, but they don't have a home. And they're the people who've been exposed to someone but have no symptoms. And then those people come in with a cough or a fever, and you're really worried about not letting them go into a 100-bed shelter or back to their camp or back to hanging out with a group of people outside. Then that second tent, which was designed for isolation, and it's quite cool. It's got beds, everything's 6 feet apart. Everyone has their own toilet, and it's rigged up the way they do in overseas. It's negative pressure throughout, so it's pretty cool. And that was about 16 beds that we got set up about a week and a half ago. It all took 5 days from conception in Jessie's head to realization with a lot of work by Barry and our staff. But anyway, that became the place we could finally send somebody. So if you see somebody going into a shelter, you could send them there. We then took our McGinnis House, our respite program, which is 104 beds on 2 floors, and we essentially made one wing of 1 floor, and soon to be a whole floor, into a COVID-positive unit. So we can cohort people who get sick with the virus and take care of them there and take the burden off the hospitals. And that is all set and is now up and going. And then we soon realized, as most of you realize, that that's just a drop in the bucket for what we need. So led by actually now Kevin Sullivan, who's our street team doc, has now is working at an old hospital that had been closed. There are 70 beds there now, so we can send symptomatic people, the overflow from the tent, symptomatic people there who we can watch and make sure that, wait for their tests to come back and make sure they don't have the virus, or if they have it, admit them to McGinnis House. And I have to stick a word in here because our McGinnis House was all re-engineered by Dave Munson, who was our street team doctor, as many of you may know, before Kevin. And so I feel like street medicine has been way involved in the redesigning of our program. And then, there's many other things going now. We've been trying to decongest the shelters and the street to get anyone who's really older, because as you know, 80% of all deaths around the world right now have been in people over the age of 60. So we do not want them getting exposed to the virus. So they are going, there's a dormitory at Suffolk now where we're able to move people there. And these are presumably people not sick yet, not exposed. So that's just to get them away from the shelter. But let me stop there. We could talk on. And what I think all of you may have been experiencing, and I'd share it with you now, is we had all this set up in the last couple of weeks, and we still did not yet have a COVID-positive homeless person that we knew of. And when I talked to my friends in like Barry Zevins in San Francisco, they still hadn't seen anyone yet. And until recently, they hadn't seen any in New York or Atlanta, but that's all changing. And what I am now worried about and would love to share with you folks as we go is the virus is about to hit us, and I think we're about to see an explosion, and we're really going to have to work hard over these next 2 months to protect and take care of the people living on the streets in particular, as well as people living in shelters. But like Jim, and I'll finish here, like Jim, we've had to change our whole street approach completely, and we can share that during the question and answer stuff. But this is really back, we went from sort of continuity of care and engagement and, making sure we take care of chronic conditions into our former real disaster mode. We're really looking at the disasters now. So let me leave it there. I really appreciate being here, and I'm looking forward to all the questions. And this is a time when I would reemphasize we're all in this together, and we can learn a lot from each other. So thanks so much.
Thank you so much, Dr. Withers and Dr. Jim O'Connell, why don't we just start there from where you left off? You said you could talk about how you've changed your approach. Can you expand on that?
Sure. Well, the change, I would say this is probably like all the healthcare for the homeless programs, whether you're in a community health center or a freestanding or a public health department. We realized that we've had to move to telehealth, like many of you have. So most of our psychiatry is now done by telemedicine, and we're learning that you can actually do that pretty well. So that's pretty interesting. We now visit people. We visit a lot of our street folks who have been placed in housing, and we now do that from slightly a distance. We try to call people quickly, and then on the streets itself, we've actually, after much debate, we really are pretty much wearing masks. We've depended on the sort of the trust we've earned over all these years, that people, when they see us with masks on, know that something is going on, something's different. We've been trying to get them to wear masks as well. And I would just share this with everyone. I'm sure you're seeing the same thing, is because the folks we're seeing on the streets, have lived through so much, and they face trauma and death every single day. And I'm sure you've seen the study that Jill Roncarati did that showed that people living on the streets of Boston die at 3 times the rate of people living in the shelters. So death is ever present. And when you say there's a hidden virus coming that might get you, they kind of shrug their shoulders and say, hey, what's new? So getting people to engage in this as something that we really want them to think about, not sharing bottles, not sharing snipes, things like that, because of this virus, has been really difficult, and it's a challenge. So I would love to hear what other people's experience are, because even the fact of wearing a mask may put a barrier up, and we've been trusting that if you've got a little bit of engagement and thing, you can wear that mask and let them know that this is serious.
Thank you. Dr. Jim Withers, you have touched a little on how your practice has changed in the course of the pandemic. So if you'd like to expand on that a little more, but also I'll ask you to do that now, and or address the question, which was one that came through with the registrations, of whether your teams are using masks or not.
Okay. Yeah, just like Dr. O'Connell said, we had to kind of look at moving from what we used to call transitional primary care, or some kind of continuity version that we try to provide on the streets, to a much more focused COVID-centric response. We realized very quickly that other needs go on, such as the need to have access to Narcan, to Suboxone, and other crucial services. So we've worked with partners to try to at least make sure that those needs are identified and addressed through CDC safe guidelines, if possible. We have decreased our teams. We're only doing 2 scheduled rounds, and then the rest of the week we have what I call Ghostbuster rounds, which is, we get called and we go out to identify people. It's outlined in the guidelines that we have, but we maintain a safe distance. And as Jim said, our pre-existing trust relationships are very important and have allowed us to continue to build a sense of community with people, and the benefits of that are really being recognized at this time, to have that background with them. The question that you asked again was?
Masks or no masks? I know you keep a safe distance.
Yeah, we approach camp, and we are wearing masks at this time. I admit when we started, we were using the 6 feet rule, but right now we're pretty much wearing masks during the entirety of our rounds, just because each of us has our own different levels of contact, so we're kind of protecting ourselves from each other at this point, as well as trying to protect the patients. We don't gown fully unless we're going to do COVID testing or direct examination. And then it helps to have a second medical person that can be masked and gowned at a safe distance, but can help handle the specimens, the collection, and just act as a support. Because once you're in a awkward camp and you're trying to do stuff that you could normally do in a controlled clinic or hospital environment, everything gets really unorganized, you find, really quickly. So it helps to have an assistant who's medically trained to do that. Other than that, we will give masks out to patients who are symptomatic and to help them avoid spreading possible COVID virus to others. And that's, unless I'm forgetting something, those are the main adaptations we've made. We
Great,
also,
thank you.
We also wash down or wipe down everything, as I'm sure you all do, our equipment. And as Jim told me last night, take off those rounding clothes and throw them in the washer every when you get home.
Thank you very much. Another question that was sent in with registration is, and this could be for either or both of you, are you finding that clients who normally stay in shelters are now choosing to sleep outside because of fear of contracting the virus in a shelter?
Can I start on that one, Jim, and let you?
Sure.
Interestingly, Bobby, that's a great question, and we did see that with the AIDS and the TB epidemics, but we have not seen it yet with this. What I think is happening, because we do, there's testing tents outside the shelters, and there's I guess most people are trying to get in right now rather than stay outside. Our bigger problem is how to convince the folks who are used to being outside to come in for quarantine or for isolation. That's been a much harder sell. But I'm not aware of, but we haven't been following this, in any kind of systematic way, but we haven't been aware of an outflow of people from the shelters outside. Our shelters are like 120% overcrowded right now, or over census, and we haven't had much break on that. We're hoping that the city, having gotten these dorms from Suffolk Downs, from Suffolk University, will be able to move people from the shelters and decongest and allow a little bit more distancing in the shelters.
Thank you. Another question is, how are you managing transporting clients that that you might normally transport in the course of your street medicine work for appointments, or in this case for isolation or quarantine?
We are still working on that in Pittsburgh. Anybody who's acute, or needs to go to the ER, we've been told by the city to call 911, and as a policy, we aren't transporting patients ourselves anymore. I think someone mentioned that in Britain, they, at least earlier, they were putting people in a car and rolling all the windows down, which I don't think is quite adequate. But as far as, routine transport of people who have needs, right now, we're working with, after hearing your earlier webinar, we're working with the hospital systems to try to get some designated ambulances that might be dedicated to that transport, but that has not yet come to fruition.
And I'd underscore, Bobby, the same. I think Jim's right. Transportation, and I'm guessing people out there, is a major issue, because you can't even do things like call a cab anymore. You don't want to put people on public transportation. And what I've noticed is 911 is called a lot more than we would like to, just like Jim is suggesting. And then I'm kind of laughing a little bit, but it's sadly laughing that sometimes you have to transport people relatively quickly, and you can't wait for a long time. So our vans from our Healthcare from Homeless program, usually driven by like Jesse, our CMO, or April Donahue, who's one of our lead nurses, they get in the van and they go pick people up and bring them over. It's a big issue, which I think is yet to be played out.
Thank you. Thank you. I want to remind everyone, please, besides putting questions in the chat box, the beauty of the council is people are sharing solutions as well as problems. If you have any solutions to any of the questions that I'm asking, or that Jim or Jim have raised as something they're still working on, if you have suggestions, please put that there. We want to this to be a learning opportunity for all of us. I will ask maybe one or two more questions. Jim O'Connell, you mentioned that you've had a hard time getting those who are living on the streets to take this virus seriously. It's so what. I imagine, but if you can speak to whether it's true or not, and that it might be harder for those with mental illness. That population is overrepresented among individuals living on the streets or unsheltered. So first, Jim O'Connell, and then Jim Withers. Any thoughts on that, or just in general, how can we drive home the importance of this? I saw one comment in the chat box of some material that can be used to educate.
I think we have to try all sorts of strategies. But having done this a little bit too long, I think, I realize that there's a sort of a culture among the really hardcore street folks, certainly in our town. And while they will listen to us and we can talk to them and do all that, and for a lot of the time they'll pay attention, but when they go back to the, living the life, struggling to survive each day, most of that stuff falls apart and they go back to their old habits. So I think it's just one of the realities we have to do. I guess what I should say is, if you've been living on the streets for a long time, you're pretty hardened in your ways that keep you alive, and to change those requires an awful lot. And we haven't figured that out completely yet. Many people will change, but there's a whole hardcore group of people that just feel they can't.
Thank you.
We haven't been at it quite as long as Jim, but certainly have seen in many settings that you have to love people just the way they are, and in a crisis like this, people are not going to suddenly become able to navigate things that they haven't been able to navigate before. I'd say there's two things that come to mind, maybe three. One is our providers that are now restricted from going on the street by city ordinances. They still have a really extensive network of trusted communications with our clients through texting and such. And so we've really worked to try to be the point person for other groups that have that trust, and transferring it over allows us to, more quickly get on the same page with someone who's frightened. There are also people on the street, of course, that are natural leaders and influencers and supports. And so we're maximizing the influencers on the street to help people stay safe, and regularly check in through texts, especially in the larger camps, to see how the others are doing. And then the possibility of telehealth is always there in case someone has a mental health crisis. We have a partner ironically in Atlanta, who's really skilled, Dr. Fry, and we can utilize her, and we're working on our own telehealth locally here as well, if someone needs crisis counseling out there.
Thank you. Which raises a question: how about patients or those unsheltered who don't have phones? What are you doing to help them get access?
We have a program now in coordinated fashion in the city where we're getting people cell phones, and a lot of the bureaucracy has been stripped away. I'm not the point person on that, but I think they're making some real progress.
That's great.
We're in the same boat. A lot of our folks will have a phone, but more often than not, it gets lost in the shuffle of everyday life. So relying on phones exclusively has been sort of a temporary thing, and then we usually have to figure out how to get a new one or find another way. For our street folks who've been housed, then usually phones are really good, and you can actually stay in close touch with them through phones, FaceTime, and other things. So that has worked out to be wonderful. But I think the real tough folks on the street will tell you right away that it's hard to just keep a phone. And I should have mentioned, Bobby, which you would be all over. One of the key things in all that is we have the National Consumer Advisory Board, where homeless folks are on the board. And in our program, the folks who are on our board of directors who are homeless have been really key in, for example, the mask, wearing a mask or not. They were the ones who encouraged us to wear the mask so that it would send a signal to their friends outside that this is serious. We're not just talking about something not serious. So I hope around the country in any ways we can to get the people we're serving to be involved in how to deal with this very unusual situation, because it requires new ways of doing things, many of which go against the principles I think many of us really wanted of engagement and high touch and community building. So when you're saying keep distance physically, you're breaking up the community you're trying to put together. So it's really helpful to have those folks involved.
Thank you so much for raising that, and we would go a step further. And really, Boston has helped to lead the way for many times, for many years. And I would say that that's essential for developing effective solutions, to rely on those with the lived expertise of homelessness in developing your programs and helping to make sure. That's part of the bedrock of the Council and Healthcare for the Homeless. And I really appreciate you bringing that out, and good to hear that it's being put to use in this pandemic as well. The principle endures all situations. Thank you. I'd like to turn to some of the questions that have come in the chat box. And one of them is, are you engaged in testing your staff, or are there any different criteria for those engaged in street outreach versus those who are in single-site locations?
Want me to jump on that, Jim? I think that is a great question and an evolving question. We currently, up until just recently, only people that had symptoms, whether they're staff or not, were getting tested. And we had, as many of you around the country must know, we had the hardest time, even in a great state like Massachusetts, getting homeless people tested when the criteria was so tough. And you had to get people to the hospital to get a test. So we worried that a lot of COVID virus might not have been detected in our population. That's why we weren't seeing any that we knew of. What we have done now is, I think what it's evolving to is tests are much more available now, and we will test people, especially staff who have been exposed. We can test them. We still are pretty much holding on until somebody has a symptom, though. If they haven't got symptoms, we're not doing it. But I think that's about to change. And I think the whole screening process, just to share with you, and I'll be curious when we do this 2 months from now, I think the virus is going to be so present in our population that screening becomes kind of irrelevant. And if 15 to 25%, as Dr. Fauci's pointing out, are asymptomatic and, a screen wouldn't catch them, then we really want to start using the rapid tests as soon as they're available, because that's the only way in the current explosion we're going to get our hands over it. So I now feel like we're wasting a lot of our time testing people and waiting a day or 2 or 3 to get it back. I wish we could really, and only do that on people with symptoms. So I hope that's going to evolve to something new. And I could wax more eloquent about that, but I think that's what we should all keep our eyes for. I think the gold standard is going to be, if you're outside and somebody's symptomatic, to be able to test them and see if they've got the COVID or not.
Thank you.
We're monitoring our staff, and as I said, reducing and have a rotation where if someone gets sick, we're not out in the field every week, so there's kind of a rotation schedule there. And we're just, our administration has asked us to check our own temperatures twice a day. I'm not sure of that evidence for that, but it's kind of along the lines of what Jim was saying. It's looking more at the symptoms and not extensively testing anybody who isn't having symptoms at this time.
And Bobby, could I add just to what Jim's saying? I'm looking at the list of everybody who's on this. I, worry in a way, maybe it's because I'm getting so old now, but I worry about how we protect the staff that's been working so hard and so quietly and so heroically to take care of folks when we've had so little access to protective gear that we should really have. So every time I look around and see who's working in our tents or who's working outside, realizing they're face-to-face every day with people that may or may not have the virus, and they're putting themselves at great risk and their families. So I don't think we should ever underestimate the effect on our staff and how much we really owe it to them to protect them as best we can, which tends to go upside down from what we're usually thinking. We want to do everything we can for the patients we're caring for, the people we're caring for. But the balance that we've been experiencing of how do you protect your staff at the same time really serve the people who need you is, I think, a struggle within every program, and something that I would expect all of you out there are struggling with. We need to protect people. It's a very ugly virus, as you all know, particularly for people with any kind of medical conditions or over the age of 50 or 60.
Thank you. The CDC has recommended that there be a moratorium on sweep of encampments. And I, especially given overcrowded shelters in some places, just want to ask each of you your thoughts on that. Dr. Withers?
Yeah, I think that was very helpful for them to suspend that. I'm sure local governments like ours have done the same, and in fact, it's almost an unprecedented. I was afraid of the stigma, which is there, of the homeless people, especially early on. They were sort of being viewed as radioactive or something, and it made no epidemiological sense. But I think it is real helpful right now to acknowledge that people need the stability that they can get outside, and we've worked hard to give options to the people at the highest risk on the streets. Our street medicine fellow developed a non-validated but helpful screening tool for ranking those that are at highest risk in the street, and we've used that with partners in the county to try to get the most high-risk people off the street. I'm hoping that some of the things that have been enacted through this crisis are going to drift beyond in terms of providing sanitation and the recognition that just because people are outdoors doesn't mean that they don't need those supports for the time being to stay healthy, and maybe having a better long-term view of this.
Thank you. Thank you. I've said that the measures that we're taking in response to this epidemic are the ones that should always have been in place, providing basic amenities to human beings as in the richest country on earth. That should be viewed as a human right. If we aren't going to provide shelter, at least provide a means to toilet and to wash your hands and basic hygiene. And those same measures are what are needed to help prevent the next epidemic. So hopefully some of these measures will, until we can house everyone, lead to better hygienic conditions for those who are unsheltered. One question before another question is some cities have taken to creating pop-up tent cities, and want to know if you have any thoughts on that.
I guess
oh, go ahead, Jim. I'm sorry. No, you go. I'm thinking.
Bobby, do you know in what context those are emerging? Are they to provide some ability for isolation, quarantine kind of options, or that? I know the economics are changing so much now that I'm expecting to see more people unable to pay rent and be tipped over from right on the edge of street homelessness out here. But do you know in the cities that are doing that what the rationale is?
Yeah, my understanding it is for isolation and quarantining, or in some cases they will go to existing encampments and try to put people in single tents and space the tents out to discourage people who often are sharing a tent. So it's been a combination.
I think it's a second choice to if the government and others can actually rise to the occasion and create adequate facilities where people do have their own rooms, even converting large buildings. If there's a way to monitor this and provides the sanitation, the bathroom facilities and such, that I think that to me is a better solution, and it's a better way of owning I think, this part of the population. That's just my opinion. But I can easily imagine collaboration to make, especially now that the winter's going away, to make something like that work during the peak of the crisis.
And I agree with Jim completely on this. I think, I think if I step back from it, I think, the only ideal solution that we have is to get people into their own homes where they're safe. And short of that, everything we do is less than ideal and has issues. So I think, setting up, as I've seen it in some of the cities going up, they seem to be really positive and important things to do. And it gives particularly people who are struggling with a substance use problem, it gives them options other than being forced to go in somewhere where they, are not ready to be. So I think the availability of those tent kind of cities or, pop-up tents gives us a whole lot of different ways to treat people who are not ready to be on their, in and away from. So it's a harm reduction move. It provides less transmission of virus. So all much, much better than staying in a shelter, staying outside in a camp. So I applaud that, although I acknowledge right away that we're all dealing with less than ideal options here.
Both of you have spoken about the desirability of getting people off the street, especially those who may be symptomatic or perhaps exposed, into single rooms. And several cities are looking at that model of renting hotel rooms as a way to provide isolation and quarantine space for people experiencing homelessness. I have a concern that if that's not done correctly, if it's not done with appropriate services, that it could be counterproductive. I remember, Jim O'Connell, many years ago, you mentioned that some people who were moved off the street into their own place without that support would decompensate. Can you both of you speak on the importance of, if we're going to move people into motel rooms, to support them, to keep them safe, that we also have the right services, and if so, what kind of services do you think they need?
It's a very good point. I've also kind of anecdotally watched people go into housing first without supports, especially in the 90s, and not make it, honestly. So I always think of it as a liver transplant or something, where you can do the technical part of it, but you need a transplant team and some way to make sure that it goes well. With the pandemic considerations layered on top of that, I think we're going to have to be very aware of whether we're putting the person at risk by taking them away from whatever supports they have, but also being creative and finding alternate ways to support people in that. I know that's not a specific solution, but I think those principles are really important to keep in mind, and it'll depend on what resources you have and locally and what you're working with. I also think we shouldn't lose the wisdom of always engaging the person. I think I haven't seen it yet, but I think we're in a situation where paternalistic and coercive kinds of approaches might emerge in the name of epidemic control. And I think with our trauma histories that many people have, that those things are really going to backfire with our population. So I think we have to just keep that in mind as we gently navigate people to a safer place.
Bobby, I share your concern along with Jim. Once again, I'd move into my less than ideal situations. So I think the motivation here is to protect people from a transmissible disease, right? That could be potentially deadly. So we're trying to get them away from congregate settings or the shelters or sleeping together outside into either hotel rooms or dorm rooms. And, if I put on my infectious disease hat, if you have a college campus where there's an outbreak of meningococcus, the first thing we do is empty the dorms and send the kids home because that's where things can spread. So we're taking a slight risk putting people just from an infectious disease side. If you put people collectively in a hotel, even though they'll have their own room, they have to come out and move back and forth. There's going to be a lot of shared activity. And the same with when you do dorm rooms. So there is a risk in this, and I think we have to acknowledge up front that this is not ideal. It's better than being in the shelter, being on the street. It's still not a great place for stopping an infectious disease. And I have, just to share with everybody that I was listening to Paul Farmer the other day. You guys know Paul, who started Partners in Health, and he's a character. But there was a discussion about how viruses can mutate and become more lethal. Like we know this virus somehow doesn't seem to be quite as lethal with young people, but gets very lethal when you get older. But it may change. And he said that we spend too much time academically thinking about how the virus mutates and don't look enough at how we socially mutate. And he was pointing out, which I think we should all think, we're going to take, first of all, you named it, there's structural violence that has happened to these people from the very beginning. There's no social justice involved in this, so we're trying to compensate for that now. But when you think of putting somebody in quarantine who has no money, right, you realize that they can't do it. So there's a whole lot of other social issues that are coming up, like who's going to support folks when they can't go out and stem on the street? How are they going to, what are we going to do to support them? Whereas most of us are figuring out how do we just get them into the room so they're safe. That's only the beginning. And how to make sure we all learn how to take care of that. We've had calls from people that are isolating, but they do not have a sense, and they can't get any food. They can't, and then they have to go out and do something. So I think we've got a lot still to learn, and we will, I hope from all of this, we'll learn to be able to be better advocates to the mainstream about how this is not tolerable.
Thank you very much, and for both of you. And when we think about people being isolated in quarantine, it's even more compounded if they have an underlying substance use disorder or mental health issue, of how that will be addressed. Just want to thank our panelist, Dr. Jim Withers from the Street Medicine Institute. We have posted that resource. It's on our website. It's on the Street Medicine Institute's website, and it's also in the resource box. And we have our really excellent and the Council's COVID-19 resources page. I really encourage you to visit that often. We are continually updating it with new resources. We're constantly hearing from people who are doing this work and people with the lived experience and incorporating that into our resources and developing them. It's policy issues, it's clinical issues, it's administration and management issues. We are really indebted to Dr. Jim Withers, to Dr. Jim O'Connell for your time, for sharing your experience, your insights, and for freely sharing. We're still trying to figure that out, and together we will make a better response, I'm convinced. And our community needs us now more than ever, so I really loved that when someone said we are all in this together. I do encourage you to come back next week at the same time. We will have our next COVID-19 town hall. The focus will be on how medical respite programs are responding to the COVID-19 pandemic. Please look in. There will be please look in 3 days. We will post this recording and the resources, and just really thank everyone for your time, and look forward to seeing you next week, where we'll be hosted by Julia Dobbins. Thank you very much.
Thank you.
Thank you. Thanks, Bobby.